Good. Okay, so this is my last afternoon with you guys. I'm so sad, so sad. Today we're going to talk about fracture and dislocation management in the backcountry. Much of this is applicable to ER setting or clinic setting, what have you, but we'll put a little bit of a flavor to it as if you're out and about and you don't have a lot with you, and what are some of the tricks you can do when these things happen. Like I said, maybe we'll make this a little interactive. I was going to use my wife as an individual up here, but I think it'd probably be better if maybe I have one or two of you folks come up. Maybe you can practice some of this stuff on each other, and I can walk you through some of the techniques, because this is real life stuff. Everybody gets injured, so it's helpful to have an opportunity. This is posterior elbow dislocation that you can see here, particularly common. Remember what FOOSH stands for? FOOSH, F-O-O-S-H, fall on an outstretched hand. Remember what I told you? The force has to transmit from the ground into your hand, navicular fracture, wrist. Remember? Colles fracture, radial head fracture, elbow dislocation, shoulder dislocation, humeral head fracture, AC separation, clavicle fracture. The force gets transmitted up. So somewhere it's going to take a hit, okay? We'll go through some of those. We'll talk a little bit about some of the commonly dislocated joints: shoulder, elbow, fingers, hip, knees, patella, ankle, TMJ. That's a really rewarding one to reduce as well. And then most commonly fractured bones: clavicle, forearm, wrist, hip, and ankle. So we'll go over some of these and, general treatment form and what you can do. So we're going to discuss the diagnosis and management. We'll show some x-rays. In the wild, we don't have an x-ray machine with you, so some of this is going to rely on good clinical suspicion and physical examination. A couple of comments that are really important. The sooner a dislocation is reduced, or the sooner a fracture is realigned and splinted, the more comfortable and the patient will be. Most dislocations and fractures are associated with a lot of intense muscle spasm. If you have a anterior dislocation of a shoulder, the muscles are in spasm. The longer you wait, the harder it is to get that reduction. When you have a femur fracture, your quads, your hamstrings are going to contract. You're going to get this overriding. It's very, very painful. Just by putting somebody in a traction splint of their lower extremity, it's going to reduce that pain that they're having. So the earlier you can address these things, the better. I work on a ski mountain, and we'll have people that'll come in right off the ski mountain, sled, they have a shoulder dislocation. I get to them within about 10 or 15 minutes. Very easy to usually reduce those. Somebody's had that dislocation for an hour and a half. They come in, because maybe they were pretty far up in the woods and they come in or what have you. Those are a lot harder because now you have this intense muscle spasm. TMJ dislocations, if you can get to them soon, you can usually reduce them. If they've been in spasm for a long time, they're a lot harder to reduce. Generally, with fractures, you want to get them into the correct anatomic position as soon as possible. You always got to be looking at neurologic vascular injuries. Remember we talked about those knee dislocations? It takes a lot of force for a knee dislocation. I'm not talking about a patellar dislocation. I'm talking about a dislocated knee. Lots of force, popliteal artery, peroneal nerve. That's why sooner is better to reduce these. And then, if you were on an expedition and you were going to be a medical lead or you were going to be with a group, ketamine is great medication to have because generally it's not going to cause too much respiratory depression, and you can get the patient kind of dissociated enough where you can do a procedure on them that might be otherwise painful. Linda and I were on one of our trips somewhere, or I'm not sure if Linda was with me, but yeah, it was in Haiti, and there was a baby that had a young child had a bad burn that required debridement in the shower every day. And what they would do is they would give a dose of ketamine, a pain relief dose of ketamine. They could ambulate the person into the shower. They could debride that under, therapeutic conditions and then bring them back. So they were able to do that without being completely knocked out or anything. So ketamine is a pretty good drug for that. Okay, first one here. Dislocation. You can see to your left, patient's right, you can see the dislocation here. That's an anterior dislocation. Usually it's going to usually be a fair amount of trauma associated with this. For people that have had recurrent shoulder dislocations, sometimes just a funny reach, or they put their hand up high over their head. Maybe they're going to brush their hair in the back or something like that, and they can cause a subluxation or a dislocation. You reduce this, you're going to get dramatic pain relief, makes transportation easier. Imagine trying to get somebody for help while they're sitting there holding their thing. If you can get that reduced and just put them in a sling, it'd be a lot easier to immobilize and transport them. You run the risk of some neurologic things. What's axillary nerve? Because you have an inferior or anterior dislocation, you can compress the axillary nerve. Always check for nerve sensation, on the forearm and the lateral deltoid and biceps area. This patient's not going to voluntarily move this arm, and this is what they usually look like. So I need a volunteer. Come on up here. Get up here. Have a seat facing the crowd. No. I'm just going to show you what some of the just have a seat there. So let's say, no, just sit up. Let's say it's we'll follow this. His right shoulder is dislocated. He was snowboarding, fell, dislocated his shoulder. So the typical position that they come in is exactly like this. Their arm is across, and he's using this hand to kind of hold his hand there. He doesn't want it just dangling. They don't come in swinging their arm around. They're usually self-controlling it, okay? So you want to try and, on examination, you're going to examine that, and you're going to feel a defect here. You'll feel a defect. You won't feel the normal humeral here. There'll be a defect. You're going to check for the pulse here. You light touch. You feel this okay. And he's going to tell you what happened. You're going to assess for other fractures, maybe clavicle, make sure there's not other things. Isolated dislocated shoulder, you're like, okay, I think I can take care of this pretty quickly. Bunch of techniques. We'll show you what some of those are. There's one that's called the Cunningham technique, which is one of my favorite ones. I would sit in a chair opposite. I'm going to take this and I'm going to just say, okay, let's just let go of your hand there. I got it. Just support it. Get your shoulders back, shoulders back, shoulders back. I just want to get him adducted. Remember, add. You're adding to the body. I want to add. I want to keep him in tight. I'm just going to be basically holding him here like this, and I start massaging here, here, and here. I'm applying a little gentle downward pressure here. I keep massaging, overcome the spasm of the muscle. I can get that reduced just with that. I don't have to be tugging and pulling on his arm. Just gentle massage, massage, massage. Little downward pressure. I keep telling them, put your shoulders back, sit up straight, relax, this and that. If that's not working, I can now just, again, keep your shoulders up, little downward pressure. I start to keep it adducted and externally rotated. It's causing him a little bit of discomfort now, What I'm trying to do is take the humeral head, and I'm trying to get it out from under because it's kind of stuck up there. The muscles are causing spasm. The humeral head is stuck. I want to try and get it unstuck, get those muscles relaxed. While you're doing this, you continue to massage here. You're putting a little downward pressure on here. And all of a sudden, you'll feel a little slippage and it'll go back into place. The first thing you do is after it's in place, you take their hand, you touch the other shoulder. If they have a dislocated shoulder, they're not going to be able to do that. So once you get it, whether it's through the Cunningham massage technique or just the external like this, you're gonna feel a little bit of a slippage. Patient's going to start feeling better, and then you're going to touch it like that. You're going to get a sling, get a post reduction. There's another one. Lie down. A couple of other techniques. If you go on YouTube for this, you'll see there's about a dozen different things. There's something called the Ferris technique. He's there like this. Right? I say, okay, just relax. Let's straighten your arm. You let go. I got it. I'm putting a little gentle traction, and I just start doing this little vibration like this. Little vibration. And I slowly start walking it out this way. These little up and down movements are fatiguing his muscles. I'm putting a little bit of traction. Sometimes maybe you have a sheet that's under his axle and you have another person on the other side applying a little counter traction on that side. This little bit of, until you can get it all the way out to 90 degrees, So after a couple, and it's slow and purposeful. You don't want to rush this. You get out to 90 degrees. I'm doing this. You go up a little bit, and usually patient will start to feel better. You'll come back. You'll be able to do this. So that's another technique. So let's have you sit up. There's one called the modified Coker procedure, similar to what we were talking about. Adducted, he's in. I'm going to take this. I'm going to keep turning. And it's a little sore when I'm doing that. My important thing is to tell him keep his shoulders back. Keep your shoulders back. Like that. Just keep going. You can start to elevate it, and you can usually get it in that way. So there's a couple of techniques, but the main thing is you're trying to get that humeral head out from under because it gets wedged up in there. Absolutely. Yeah, I'll show you. Lay down with your head down this way. On your stomach. Prone. If you can get the person prone, let's say it's his right arm, try and get them to hang it. You tell them to come to the side a little bit. Have them hang it. Sometimes put a little bit of a weight on it. You can do scapular manipulation. You take the scapula and you try and push it this way. You're relieving that glenohumeral joint by scapular rotation. Sometimes I'll have them, if they can, hold a little something, hold a little bit of weight. That'll pull that out, and that can sometimes reduce. People love that. If it's really busy in the ER, sometimes you just put them on a stretcher like that. You tie a little weight in the ortho room to their wrist. There's a little strap you can do, and just say, okay, I'll be back in about 5 or 10 minutes. And just the slow weight, because again, you want to fatigue these muscles. Fatigue these muscles. Sit up. All right. Again, he's got a shoulder dislocation, right? You say, okay, let's say it's his right shoulder. You're out in the field. You're by yourself. Okay. How do you reduce it? You have a technique for your own. You don't need to do what Mel Gibson did in, was it Lethal Weapon or whatever, where he slams his shoulder. You don't need to do that. Lie down. So dislocated shoulder. You're out in the woods by yourself. You fell. You've had dislocated shoulders. You try it. It's not working. Bring your knee up. You want to have the patient try and gently sit up, lock their hands here as best you can, and then just let your own body weight back, and you just put your head back, arch your shoulders back. Just that weight, that slow traction on the muscles, and he's going to basically get that humeral head out from under there. And then he'll know when it's in because the pain will go away. And then you'll sit up and you'll say, okay, let me get off the mountain. Let me get back to help. Okay, thank you very much. Have a seat. All right, let's see a couple of those things. So those are the general things. But what you want to do is you want to fatigue the muscles. Fatigue the muscles. Adduction, external rotation. Slowly. You don't want to be jerking on things. Jerking on things is not good. I had a colleague who was doing a hip dislocation on a little old lady. He was sitting in, he was going a little too aggressive, snapped her. She had a very osteoporotic, caused a femoral fracture. You do that same thing on a little old person, you start jerking their arm around, you're going to cause a humeral head fracture. So you got to do slow, and you want to fatigue muscles. Let's see, I got a couple of examples of it here. We saw that picture, schematic here. Again, most of them are anterior, inferior dislocation. This is the way they look when they come in. They can't bring their arm across and touch their other shoulder. You see the loss of normal contour. So let's see. Here we got a couple of different techniques. Let me show you that Cunningham technique that we talked about. You see his left shoulder's dislocated. You see that all right?
What I'm going to do first of all is very gently just move your arm around to the side. If I can get you staying set straight up forward.
You can see the patient's left shoulder. Obviously, different anatomy, right? Looks very different.
Sit next to you there.
This is the one where he's going to massage.
I would say let it go. Okay, because what's keeping it out at the moment is a muscle spasm. So it might feel a bit strange. It might feel a little bit of a slip. Try to relax as much as you can if that happens.
Tell him to relax his shoulders. Try and get his shoulders back. Sit up straight. If if they're on a stretcher, get their back against that. You can do this in a chair. See, he's got that arm adducted. He's putting a little bit of downward pressure. He's starting to massage, squeezing the biceps. Get your shoulders back. He's not yanking on anything. Get your shoulders back. Slowly fatiguing the muscle. Got a little downward pressure. Adducted.
Just relax for me. Just keep the arm in at the side. A little bit slouched over to the left side, so we'll try and correct that as well. There we go. Okay, all done. All right.
There's no big clunk, no big dramatic thing. You don't want to hear a clunk. The sound of a clunk is when bone is hitting bone. You can get what's called a Hill-Sachs deformity in the humeral head if you're aggressively. Question? Go ahead. It's just relaxing the muscle. You're massaging it. You're massaging it. Remember, those muscles are all in spasm. You're trying to relieve that. Up here, here, and here. I did this one time. Guy came off the ski mountain. He had a badly dislocated, big muscular guy. The staff, this was up at Stratton, Vermont. The staff there was, oh my God, this guy's big. We're going to have to give him sedation, some propofol, something like that. I'm like, oh my God, it's towards the end of the day. I want to get back out there and get another run in. I don't want to go through all that. So he was sitting on a chair. Before they even did the x-ray, I started doing the massage technique, getting the shoulders back, shoulder went right back in. So you just want to fatigue these muscles. They're all in spasm. I think we got another example of that. Oh, shit. Let's see this one.
We're going to take the weight. Okay. Just bring it into the side.
And you see the defect in this patient's left shoulder. It's not rounded like this.
We'll bring that into the side. So that's just the weight of my arm.
He's putting a little downward pressure.
Now what I need to do is try and sit straight to the
See him starting to just kind of gently massage the biceps there. Massaging the triceps.
Bring the arm right into the side there.
Shoulders back.
Okay. Is that painful at all? Good. Shouldn't be. So relax as much as you can. Is that painful to help you relax? That's sore, is it? Okay, good. Can I get you to sit straight up for me? Really shrug the shoulders right up. Bring the
While we're doing this, I
right
might try and do a little external rotation there.
Try and relax as much as you can with the arm. That's it. The arm right up.
Remember, he's pulling. See how he's probably pulling down with his left hand on that a little bit. Massaging.
Now we'll just relax the arm as much as we can.
A little downward pressure.
That's painful. That's it. Relax as much as you can. There we go.
Boom.
All finished.
Not a big dramatic thing, but the patient will suddenly feel better. I want to show you one more technique here.
And now for the part you've really been waiting for, which is how do we put
great.
this thing back in? How do we reduce this dislocated shoulder? Now, I used to work in Telluride, and we'd have residents come from all over the country. They wanted to see pulmonary edema, and they wanted to see dislocated shoulders. So I would often be busy. The resident would be working on the patient, and I would say, how you doing? And I'd come back in, no luck. And oftentimes it's because the patient
like this
was looking at the resident like they were A, scared, and B, hated the resident's guts.
You want to get the patient
This is what
calm.
a patient looks like when they hate your guts. They suck their shoulder in, and no matter what technique you use, and there are a whole bunch of techniques, whenever you start doing this, you're not going to get the shoulder in. The way you get any shoulder in, I'll show you my favorite technique, but there are a million of them. But the way you get a shoulder in is by getting the patient to relax and give you their shoulder. So the way that I try to get a patient to relax is by using something I call verbal anesthesia. And I literally tell the patient that I'm going to reduce their shoulder, that I know what I'm doing. You can lie a little bit if you have to. And I've done this a million times. But most of all, I try to get the patient to relax, because if they've seen too many
confidence in you. If they're
Mel
scared,
Gibson
they're going to be
movies
tense.
or cowboy movies, they think you're going to come up to them and go, "Hi, I want you to," and so you have to convince them that everything you're going to do is going to be nice and controlled, and you're using the verbal anesthesia, and you're touching them with confidence, and now no matter what
Calmness
technique you use,
begets more
often the
calmness.
shoulder's going to go in. The technique I really like to use is a technique called the snowbird technique. It originated in Snowbird, Utah, and it goes something like this. So I'm going to use a strap to pull down on Denise's arm to create
Like,
traction.
you're probably
towards
going
the
to have a
floor,
strap
to
or something you can
distract.
use. You can improvise.
Now,
with.
I've talked to a lot of orthopedic surgeons that say, well, this is a fine technique, but you really don't need the straps. The reason I like the straps are because if we use just muscle to push down and we're a little nervous, we're often doing this sort of like, don't worry, I'll get you in. Whereas when you can just step on the strap and provide traction
Let
with your
gravity do
foot,
the work for
it just makes this go very smoothly. So let's put it on. Normally I would just use one strap, but I'm standing downhill, so I'm going to use two straps just so I'm not out of balance.
Sitting up on a log.
I'm going to
or a
slide it
rock
over
or
the
something.
patient's arm, just like this. And normally I would pad this, but Denise has a couple layers on, so I think we're good. And then I'm simply going to stick my
You can't
foot
see it, but
into
he's
the
putting
strap
weight down on that. That's that.
and use my
That's that
body
traction
weight
down, right?
to push down. I'm keeping Denise from leaning towards me by pushing her away here. Or if I was standing up, I could support her like this. You could also have another operator on the opposite side providing counter traction. This technique involves traction towards the
that
floor
slow
and
downward
ultimately
is
some external
fatiguing those
rotation.
muscles,
So all I'm
right?
doing
Without a
is
lot
I'm
of
pushing
stress for
towards the
him.
floor with my foot. And the question is how much? And I would say just enough. But it's quite a bit of pressure towards the floor, pulling her humerus down
Remember,
towards
it's
the ground.
adducted during this.
And then at some point, a little external rotation, and typically she goes back in. To recap, I simply put some kind of strap on. This can be whatever you got. You want to pad it nicely so we're not putting undue pressure on her arm. And we're just going to slide our foot in to whatever strap we've set up and push down towards the ground. After applying that traction, we're going to externally rotate, and typically she'll go in. As long as she's relaxed and she's given us her shoulder, she'll go in. If she hates me and sucks her shoulder away, then you get into this kind of thing and it's not going to go in. After you get the shoulder in, there are a few things I'd like to look at before I go ahead and splint her. The first thing is I'll redo my distal neurovascular exam. Can you feel this? Mm-hmm. Move all your fingers. Is your pulse okay? Yeah, got a good pulse. And can you feel me when I do this? Mm-hmm. So she's intact. That's good news. And I can document that. The next thing I want to
We don't need to see it, but and then you could do a makeshift splint or a sling rather with a t-shirt just by strapping something around. You can do a necktie sling where you basically just put that same strap around the neck and just hold the wrist like this. You like to have it tucked in against the body. If you do this and then they start hiking again and they're swinging their arm or they're using their trekking poles, good chance it's going to cause them a lot of pain, and two, it may redislocate. So in summary on that, remember, slow, gentle downward traction, adduction, gradual external rotation, massage of the muscles, get them to relax. This last one, the Boss-Holzak matter technique, is what I was showing here with the self-reduction with the knee. Let your own body weight. That's the one where you're up there and you just let your body relax. You put your head back. You let your body relax. I'm putting traction on that, on those muscles there. And then slowly that'll slip back in. And then I can get down off the mountain or continue on with whatever I was doing. Any questions on shoulder reductions? Okay, elbow reductions. Let's get a different person up here. Somebody jump up. Have a seat. Again, this is a FOOSH. Fall on an outstretched hand, forces up to the elbow. It's generally going to be a posterior elbow dislocation. Okay, posterior elbow dislocation. He's going to be in a lot of pain. This is extremely painful. Patients are very, very uncomfortable. They come in supporting, again, now they're really supporting it. They're generally not, they're kind of like this. They can't bend that elbow much at all. And there's an obvious deformity. The olecranon is sitting much more posterior. There's a defect here. You got to be always kind of assessing that neurologic status as well. So, I'm going to, do you feel this here? You're checking for pulse. You reassure that patient. What he was saying, that verbal anesthesia, if you can get your patient nice and calm, there's a very good chance you're going to have a better success. If you come in, like he said, if you start yanking on things or you're hushed or you're rushed and doing this and that, it's going to be very hard to get that patient relaxed. So one of the techniques that I like to do, it's basically the handshake. What's your first name again? We're going to take good care of him. I'm going to say, we're just going to shake hands. Don't worry. I'm going to take good care of you. Now he's in this particular position, very uncomfortable. I can feel his olecranon with my fingers here. Feel his olecranon with my fingers. I'm going to be applying a little bit of downward pressure on the olecranon while applying a little bit of force forward with the handshake. I tell him, relax. You don't need to grip my hand. Let me do it. I'm applying downward pressure. He's a pretty big muscular guy, so I want to kind of overcome those. So it's a slow downward pressure while I have my fingers on his olecranon, and I'm pulling that forward. So it's down with your thumb, forward here. If I had a second person that was helping me, they might be pushing back here while I'm pulling. But the main thing is downward here, down, and pulling forward on the olecranon. And as I'm doing that, I'm kind of using it like a fulcrum, and I'm bringing it up like this. What you don't want to do is have the patient pronated like that. That radial head will get stuck. You'll never get it out. So you don't want it pronated. You want them in a relatively neutral position, downward pressure, and pulling forward like this. Once you get, and you're gradually doing this, suddenly he'll start feeling a lot better, okay? And then you're going to put that one in a sling. I'll show you that schematically here. Traction applied, counter traction to the humerus. If you have another person that can help you, steady, slow, steady. Remember, slow, steady wins the game. Once you can flex that to 90 degrees, it's going to be reduced. If it's not reduced, you're not going to be able to flex it to 90 degrees. I can be pulling on that olecranon as well. This says push, but it's really pulling on the olecranon. It can be a very difficult. Let's see. We got one here. Most common dislocation. Counter traction, downward pressure. This one's grabbing the wrist, not pulling on the olecranon. Gradually flexing. It's kind of stuck. There you go. And then you can flex it to 90 degrees. Let's see this. That guy Cunningham from Australia. Let's see his technique. This is the one-person Cunningham. Handshake position. You don't want it pronated. Remember, that's what it should look like.
What I'm going to do is very gently get hold of your arm, and then I'm going to move it up a little bit. Let me do all the work. Take control. I'm going to hold on here, so you grasp firmly here, taking a hold and getting control. you do a handshake. Okay, and at this point here, we're actually looking to move from a extended position to a flexed position. So we're starting off in this position here. What I don't want is pronation, because that will get the radial head in the way. So I want either a neutral or preferably a slightly supinated position. I'm going to get you relaxed now. So don't grip on me. Let me do all the work. And then I'm doing a firm.
With his
gentle,
left hand,
steady
he's got his
traction.
fingers on the
So I'm
electron. He's
pushing
pulling
in
that
this
forward.
direction here. And then I'm walking up like this.
That little bit of side to side helps kind of
And
disengage.
the elbow slips back in. And you pop it back down again.
Once you get to the 90 degrees, you're in. It's pretty obvious once you get it in.
Yeah.
You're grabbing that olecranon, you're trying to get it up over that little area while traction and then flexion. I think there's one more two-person technique here. This is easier with two people because you got somebody applying. So you got somebody, and he's not pronated, somewhat supinated. Oh, you see it go back. He was putting downward, and he was kind of walking up. That person was sedated, by the way, pretty snowed. You heard the big, ah. Yeah. When do you know it's I can't really tell you for sure. You're kind of doing everything at the same time. You're pushing down, you're pulling forward. You'll probably feel some resistance, and you slow down, a little more downward pressure, gradually start to flex. Gradually, as you start to flex that elbow, you'll feel what you'll feel. You don't want to use it. You don't want to do it real fast. You want to do it nice and slow. So it's continuous downward pressure while you're starting to flex it. And then it'll just get to a critical point, and then it'll just slide back in place. Do you have a question? Let's just see that one again real quick. Oh, different one, sorry.
So we're just going to have a look here first of all, and we have a look at the different.
It's this one. In this particular one, he's got somebody applying traction this way, and he's up here trying to milk that. He's pushing down, but with his other hand, he's sliding it forward. Down, forward. I've been sedated and moaned, but I feel better. That's elbow dislocation. Let's see what else we got here. And then you splint them, or you. Common injury in basketball and football. You see this all the time. So dislocated, MCP, PIP, DIP. So this is a dislocated PIP, proximal interphalangeal joint. This is the DIP, distal interphalangeal joint. And this is the metacarpal phalangeal joint. Okay, so this is a PIP, pretty common. You don't need an x-ray for this one when you see them come to the ER. Painful sometimes. Sometimes they come in and it's not actually really that bad. This is pretty easy, but what you want to do, sometimes you can get little plates there that get stuck. So what you want to do is you want to kind of reproduce the injury in reverse. Reproduce the injury. So in this particular one, I'm actually going to dislocate it a little bit more. I'm going to bend it down, and then I'm going to slide it up. So it's in this case, starts with some, if I just started cranking that thing to straighten it, it's going to get hung up there. So I want to kind of disengage it by pushing that mid phalanx down. Once I get it down, then I can slide it up and straighten it back out. You always want to check for perfusion on this. The digital arteries there can be a little compressed on that. So just looking at the finger, the color of the finger, kind of document that, and sensation. And then we'll talk about what you do after it. So let's just do let's see if we got one here.
Hello everybody, Dr. Carlo Oger here for edexitvideo.com. This picture shows you a dislocated left fourth finger. Patient fell and the finger went the wrong way. Patient actually was not in too much pain. This is the x-ray showing the dislocation. Absolutely no fracture. Patient was actually saying he didn't have any pain. Anyway, we did a thecal block and
digital block.
which is
I don't even
a
think you need to do
midline
that
palmar
necessarily.
side injection of numbing medicine. And just gave it a gentle tug and went right in. You can see the patient immediately felt better, fully able to move the finger.
Did a digital block so the guy was numb, didn't have any pain.
No.
I don't even think it's really worth doing that. There's a better one for that. Let me just see if this is it. MRAP's got a bunch of great videos out there.
I'm Dr. Jess Mason, and I confess that
So this is
reducing
not
a
a
finger
lateral
dislocation is a
dislocation.
true joy of emergency medicine. It's fixable and gratifying
PIP.
for all involved. This
It's not
X-ray
a
confirms a
lateral.
volar dislocation at the PIP joint of the fifth finger, which
it's a
is actually
volar
more rare than a
dislocation.
dorsal dislocation. Some patients
Or
just want you
dorsal
to pop it back
dislocation,
in,
rather.
but I do offer patients a digital nerve block if they want it. Prep the skin, and there's several techniques for digital nerve blocks. The one that I'm using here is the web space approach. The
Shouldn't
needle's
use
inserted from the
epinephrine,
palmar
just
side to each side of the base of the
lidocaine,
finger
not
along the
epinephrine.
course of the digital nerve. Aspirate and inject 1 to 2 mLs of local anesthetic. You can see blanching of the proximal phalanx and duskiness distally, probably due to the
You can do
fluid
it just
injected,
on the
which
palmar
decreased
side.
blood
You don't
flow.
need to do it on
This
both
is
sides.
transient, but a good demonstration why we need to be cautious with the volume that's injected. The reduction technique makes sense when you review the X-ray. First, brace the finger at the proximal phalanx to provide countertraction. Second, pull axial traction to disengage the middle
And
phalanx
that one,
from
I'd
the
actually
proximal
flex
phalanx.
it a little bit more
Third,
and then
pull
pull
the middle
axial
phalanx
traction.
back into place while extending the finger. The same concept is used for dorsal or lateral dislocations. Again, brace the proximal phalanx, pull axial traction,
You
and
saw
pull
that.
the finger back into place. Let's look at another finger dislocation. This time it's the ring finger, PIP, and it's also in a volar direction. Remember, the direction is defined by the distal portion, and in this case, that's going volar or palmar. After your digital nerve block, brace the proximal phalanx, pull axial traction, and pull that finger back into place.
See, pulling really
After
hard. If
reduction,
you
check
flex
for
that a
full
little
range
bit,
of
it
motion of the
disengages it. I
finger,
found it a
which
lot
might be
easier.
a little limited due to pain and swelling. This includes checking for lateral stability and also checking the flexor digitorum tendons. To test the flexor digitorum superficialis, brace the other fingers in extension and ask the patient to flex at the PIP joint. To test the flexor digitorum profundus, brace the finger at the middle phalanx and ask the patient to bend at the DIP joint or the distal knuckle. Both of the patients shown actually had anterior dislocations, also known as palmar or volar dislocations. Yeah, all three names. So that's high risk for a central slip injury, and we need to do an Elson test to assess for that. Have the patient curl their fingers around the edge of a table or a box with their fingers flexed at the PIP, and then they extend their finger while you apply pressure to the middle phalanx. If the central slip is intact, you'll feel tension as the finger is extended. In this case, there is not much tension, which is concerning for a central slip injury. So this patient needs close follow-up with a hand surgeon. For volar dislocations, splint and extension for 3 weeks. For dorsal dislocations, you can either splint in 30 degrees of flexion for 2 to 3 weeks or buddy tape for 2 to 3 weeks if stable. Lateral dislocations can be buddy taped for 2 to 3 weeks.
So buddy tape is basically you're taking that finger, I put a little cotton between them, a little cotton ball or a little gauze. You're going to tape them in a position of comfort. Again, you can opt to do the digital block if you want. A couple of things, clues on digital block. Number one, you don't use epinephrine when you're injecting into a digit, an ear, or a penis, because the flow comes from one direction. If you get intense vasospasm, you can cause ischemia. The other thing, when you're injecting and doing digital blocks, you need to aspirate back to make sure you're not in a vessel when you're injecting the the solution. And I usually load them up pretty good. I'll load them up pretty good. I'll make one particular stick. I'll go a little lateral, then a little medial. I'll use probably anywhere from 2 to 4 cc's. If you put too much in there and you get too much pressure in there, the whole finger goes white and you're like, oh shit, did I do something wrong? Because now there's so much pressure in there, it's compressing the blood vessels. So limit the amount. And then what I usually do is I tell the patient, okay, just hold this little gauze on and rub that area, rub it. I let it sit for maybe 3 or 4 minutes. Let them get good anesthesia in there. And then I'll do it if I'm doing a repair or if they're really, really tender for a reduction. But sometimes it's easier to just kind of do that verbal anesthesia and reduce it, because once it's in, they feel instantly better. Hip reduction. Let's get different, somebody up here. Come on up. Let's go. What's your first name? Come on. Majority are posterior. Lay down on the stretcher. All right, he's going to be in it with a hip dislocation. Most are posterior. He's going to be slightly flexed. He's going to be a little bit internally rotating. He's going to be adducted. So they're going to come in looking a little bit like that. Okay, it's uncomfortable for him. If you had a dislocated posterior hip, that would be your position of comfort. You'd be in that particular position. Couple of things with this. Why do we want to get these in right away? What's happening? Vascular compromise to the femoral head. If these stay out too long, you can get ischemia, you can get complications later on. A friend of mine, Sheila's son, was in a car accident, posterior dislocation of the hip. This is a dashboard injury. High speed motor vehicular accident. The car stops suddenly, slides forward. They hit their knee on the dashboard. They'll sometimes come in with a laceration on the knee. Everybody's getting attention, of big gash, but the real problem is in the hip, because with that, they had a posterior force on the hip. So they'll come in like that. Always assess for pulse, sensation below the extremity. This one is better with a 2-person technique, and we'll show you how to do that. If you were alone and you did this, you can take a strap and somehow put it down and secure his hips and pelvis down like this. Because remember, I'm going to be applying a lot of upward pressure on this, So you need to keep the hips down. If I had somebody that was helping me, I would tell them, okay, just stabilize the pelvis like this so that I can reduce the hip. There's a couple of techniques. And generally with hip dislocations, if you're in any kind of setting where you can give some analgesia, he would greatly appreciate it, because this is generally pretty painful. You want to slowly get them up to about 90 degrees like this. And then I'm going to, with my arm, I'm going to put it under here. I got somebody holding his pelvis down, and I'm going to start to lift like this. So I got somebody holding his pelvis down. I'm lifting, and then just at 90 degrees like this, you'll feel it pop in. There's a technique, the Captain Morgan technique. If I had a little bench, I would show you. I would be standing on a small little bench. I would put I can't really do it here, but I would put my leg up underneath that. So I would be standing elevated. I'd get under, and I would use my knee under here, and then I could just lift it by flexing my leg. I have a demonstration of it, but the concept is the same, because it takes a lot of force. I'm pulling up pretty forcefully like this. Someone's keeping his pelvis down, either with a strap or manually, pulling up, and then you'll feel it pop. Then when you go back in, you get them into a position of comfort. Sometimes you strap them like this while you're sending to X-ray, or if you were out in the field somewhere, they're not going to be able to walk right away on this. So you would want to splint them to the next leg and try and get them down off the mountain or something like this. Let you sit up. Okay, thanks. We'll show you a couple of techniques for that. It's painful. Generally, 2 people is easier. Upward traction while holding the pelvis stable. This is the one I told you my friend was doing, one of my colleagues who ended up causing a femur fracture in this, in somebody that was very osteoporotic. A lot of force involved. That's the way they come in, shortened, adducted, internally rotated. I'll show you the Captain Morgan. You know,
we're going to discuss a technique called the Captain Morgan technique for the reduction of a hip dislocation. It's named after the pirate on the Captain Morgan rum bottle who has his leg up on a bottle of rum in a rather classic pose. The first thing that must be done is the patient's hips, in particular the pelvis, must be anchored to the stretcher. If the hips and or the pelvis is not anchored to the stretcher, the patient's body will be lifted off the stretcher when you try and elevate the leg to reduce the hip. To do this, a sheet is placed over the pelvis itself and anchored to the stretcher. To anchor to the stretcher, on one side, it is anchored to the frame with a knot, and then passed over the top to a smiling technician on the other side, and then passed back under the frame so that the technician can just pull on the sheet as it passes under the frame, and that will anchor the patient's pelvis to the stretcher. Patient is sedated with a drug such as propofol for procedural sedation.
White stuff
propofol
in the syringe,
is selected
great
because
drug.
of its muscle relaxation effects as well as its sedative effects. Patient's leg is elevated and the operator's leg is placed onto the stretcher with the patient's knee going over top of the operator's knee. The operator then lifts the knee up using his foot and the hip pops into place. You can see the hip pop into place nicely on this.
Once I'm up like this,
again,
I'm using my foot.
The knee is placed over the operator's
like
knee.
So I'm using this
the operator
force.
lifts his
Downward
foot
force on the
and
pelvis.
the hip pops
I'm
in.
using my strength.
Even with
to
the
pull
strap
it
in
up.
place, sometimes some additional pressure on the pelvis is needed to hold it in place. Once the hip is reduced, the strap is removed and a post-reduction x-ray obtained. There is an excellent article describing
another example. I think this is a 2-person without the sheet. This person actually has a prosthetic hip in place. Again, they look the same, shortened, internally rotated, adducted.
Yes.
Okay. Flex. Somebody holding the pelvis down. Somebody checks the curtain leaves. He's just trying to disengage. Just trying to get a little bit of movement on that. There you go. Ouch. That hurt.
So we'll make this an abduction here.
I might show that in slow motion without the sound. 90 degrees, adduction, upward traction. He's doing a little rotation. The guy pokes in the curtain and leaves. Little rotation. He's just trying to disengage it, fatigue the muscles. Now he's going to apply his upward traction. You can see how that guy broke that lady's femur. Nope, there you go. That one you generally feel a clunk. Time is not as critical when you have a hip prosthesis in there because you're not worried about vascular compromise, but the patient's generally uncomfortable. All right, there's other techniques there, but I want to get to 1 or 2 of these other ones there. So this is a knee dislocation. Knee dislocation, big disaster. I think, I'm trying to remember which football player it was, had a horrific, I think he was a running back for the Georgia Bulldogs, had a bad knee dislocation. He's playing in the NFL now. He had this injury. It's pretty catastrophic when you see this. Who was the running back on now? I'm trying to remember. Major ligamentous disruption. Even once you get this reduced, they're going to need reconstructive surgery on the knee. High risk for a vascular or a nerve injury. Very, very, very unstable. Just because of time, we're just going to jump to this real quick here. got somebody pulling traction on that, and you see a slip. So again, it's not that dissimilar to the elbow. Traction, and he's kind of hooking that and pulling it down. You can see the difference between the two legs. I think I got another example of it here. And then you're going to immobilize them in extension with a knee immobilizer. This is a posterior knee dislocation. That last one was an anterior dislocation. Posterior knee dislocation, this one. You can see.
So in your car accident, what
This
did
is
you
a car
hit with your
accident,
knee?
when I was telling about a dashboard injury. Notice the laceration on the
Was
knee.
it a head-on accident or?
This can also cause that posterior hip.
Hit the back of a van.
Hit the back of a van. Got it. Okay.
I'm going to jump over on this one.
Board 2. Are you awake still?
They've given him
Are
something,
you
probably
awake?
not enough yet.
So did you see any fractures on the X?
Let's go back a little bit. Pushing on the femur.
So he's got pain medicines already on board too.
This guy's sedated.
Are
Usually you need to
awake
give them
still?
some sedation with this.
Are you awake?
Are you
No, I think he's out. So what are you doing? Explain to us.
Just pushing on the femoral condyles here. Trying to release.
Oh, you felt it.
When you hear that, oh, you know you got it in. Then you're going to put them in a knee.
So did you see any fractures?
That's a great sound to hear with these reductions. Okay, you're going to immobilize that in extension. Let's see what we got next. I think we got one or two more. The patella one. Linda, come up here. Lie down on the stretcher, please, honey. Face that way. Bring your left knee up. Okay. So Linda has a patellar dislocation here. The patella is sitting laterally. Sitting laterally. She's in a lot of pain. Are you okay? Do you want me to get your husband? All right, so she's in a lot of pain. They say, should we take her to x-ray? I say, no, we're going to just fix her. So I'm going to take my two thumbs like this. The patella is dislocated laterally, right? Take my thumbs. I'm going to feel that patella, and it's going to be a very simple maneuver. I'm going to be putting pressure, medial pressure, and I'm just going to go, and it's right back in place like that, okay? Right back in place like that. Now I'm going to show you. Let's have you sit up. Thank you very much. I'll let your husband know you're okay. I'm going to show you the not so easy reduction on this one. Immediate relief, flex with laterally displaced patella, extend the knee and push the patella immediately. It gets back to the normal position. You can immobilize it with or you can splint it with whatever you have. All right, so here's somewhat of a failed reduction here. Things don't always go as you expect, but this one's generally really easy. But this guy manages to botch it up, I think.
So we're gonna be doing a patellar reduction. This kneecap or patella dislocated from watching video games.
Dislocated
sitting on a
watching
knee.
video
I've never
games.
heard of that, but that's interesting. Okay.
Yeah. And so what we're gonna end up doing is I'm gonna bring him into flexion, and when we do, my assistant's going to, as I extend his leg, he's gonna relocate
Bring him
and
into
translocate the
flexion.
patella into
Yeah,
midline.
but you want to really
Okay.
extend
So
it.
what have you done for pain?
We did 2 milligrams per kilogram or 100 milligrams of nasal ketamine and 1
They gave
milligram
nasal
per kilogram.
ketamine. I don't even know why they
fentanyl.
give that. It's so
Okay,
quick.
or 1
Just-
microgram per kilogram.
Sorry, 1 microgram.
Okay. It's gonna hurt for a second. But it's gonna go very fast.
All right.
No, no.
And you can yell if you want.
no.
Ready? Ready? 1, 2, 3. Oh, it didn't go.
Nope, not going too well. Oh, he got it finally. Oh my God, that hurt me. That hurt me.
Yeah, knee immobilizer next.
I don't know if I was doing that one, if I would ever put that on YouTube. And there he goes with a knee immobilizer, not actually having any recollection of what just happened. Let me show you how it's supposed to look.
Today on Fracture Fridays, let's talk about how to reduce a dislocated patella. So usually the kneecap is dislocated when the patient
Laterally,
hyperextends
you can see
their
the
leg,
kneecap
like
right
landing from a
there.
jump. Almost always you're going to see it displaced laterally and the patient is going to flex their leg. To reduce it, you're going to firmly grasp the patella. Yes, firmly grasp it. And simultaneously, while you're rotating it back medially, you're going to straighten the patient's leg out.
That one went right
As
back
you can
in.
see
That
here, it
poor
pops
other
right
kid.
back
I
into
can't believe
place.
that was so painful.
Generally,
for
the
him.
patients are just a bit more comfortable after that's done. You want to provide a splint for comfort, crutches as needed, and then they can follow up with their primary care doctor, an orthopedist, or sports medicine. While doing this procedure, it's probably a good idea to provide a little bit of pain control as well.
Nah. So again, you see the lateral displacement of the patella. It's kind of the patient's in the flex position. It's kind of stuck there. You want to kind of relax that by straightening it and then kind of popping that patella back over. I like that one. It's fun. Okay, what do we got here? We got an ankle a dislocated ankle, right? That looks pretty uncomfortable. These are the ones that present with its obvious deformity. You see tenting of the skin, and you're like, oh man, I got to get that back in right away. That looks really, really uncomfortable. Patients feel immediately better. I don't usually wait to call the orthopedist on this one. I say, I'm going to do this one right away because, and I'm going to say, yeah, there was a little bit of sensory little bit of sensory loss there, or the pulse field a little bit weak. So I need to do the reduction right away. I don't want to wait an hour for the consultant to get to the bedside. So I would usually do these ones myself. Generally going to have a fracture with them, but it doesn't matter. You still got to reduce them. Circulation may be compromised. Everyone I had a slightly decreased pulse. You're going to apply traction to the foot and the ankle with the knee slightly flexed. You'll splint after reduction. We'll show you. We'll show you how to do this one there. Trick is you want to have the knee slightly flexed with this. You don't want it in full extension. You want a little bit more relaxed. Pretty obvious when it comes in.
Turn our flip around. Here. And hold. You need to hold it taut. All right.
Again, he's cupping that heel. He's going to be pulling that heel. You got somebody holding counter traction.
False. You guys ready?
1, 2, 3.
3, 2, 1.
You're going to apply traction. Try and unhook it, and then you'll straighten it back out. You quickly check for a pulse again. Oh, wow, that pulse got better.
The ankle is dislocated, you need to have a pulse in it. So you kind of do that.
DCS 15.
Okay?
You hold it in that position. Hold it with the hand under the heel. Hold it in that position. You get some kind of temporary splint on it there, and then send them off to X-ray. I think we might have another schematic of that. We're almost done. Let's see what else we got.
Of one or more of the malleoli. Position the patient
fracture with
supine
it
in
too.
the bed and flex the knee to relax
Flexing the knee is
Achilles
important.
tendon.
If the knee is extended, you're going to
Instruct
have a hard
an
time
assistant
with
to hold
this.
the patient in this position during the reduction maneuver. Grasp the foot with both hands, placing one hand on the heel and the other on the forefoot. Slightly plantar flex the foot and apply axial traction. Instruct your assistant to apply downwards pressure to the tibia to stabilize it. Then pull the heel anteriorly to reduce the distance.
And then what I usually do is I hold them by the big toe and I just hold it up like that. Let the weight of the lower leg just kind of hang there. Maybe I have my hand under the heel a little bit, but I'm just holding the foot up. I've got some stuff prepped. I get a little posterior splint on there. I'll wrap it up and then they go off to X-ray. It's really gratifying when you get these things reduced. You feel so good. And they feel better too. Okay, we're probably not going to get to the fractures. We'll finish up with TMJ dislocation. Has anybody ever had a TMJ dislocation? Yeah, it's pretty uncomfortable if you've had that. You can either have a unilateral dislocation or a bilateral dislocation. Patients will come in like this. They can't close their mouth. They're usually drooling a little bit. And it's usually due to either an exaggerated yawn or going to bite into an apple or something where you're taking a big bite into something. By over opening the mouth, you're going to cause the temporomandibular joint to slip forward. So we'll show you a couple of techniques here. The jaw gets locked in that position. Show you this. I think this is pretty good because it shows you the anatomy here a little bit. This isn't the one. Couple of things. Stand in front of the seated patient. Usually what I do is I have them sit on the stretcher. I have a little small little step stool there. I'll stand up on the step stool. I take a 4x4s. I wrap my thumbs and tape them so my two thumbs have a little padding on them. I have the patient sitting up. I'll tell them relax, relax. They're sitting there like this, looking at me. You get both thumbs and you grab their posterior molars. And I'm going to apply slow. I'm going to, again, hook my fingers here behind their jaw. I'm going to hook my fingers. As I'm applying downward pressure on that, I'm going to try and slide that back under. So it's down and under, down and under. Because their masseter muscles are in spasm. It's holding the jaw out of place. So I want to slowly fatigue. There's a technique where you can do, you guys know what a tongue blade is, the little wooden popsicle stick? You can take tongue blades, you take maybe 10 or 15 of them, and you tape them together, and you slide them into the mouth. Slide them posterior in the mouth, and you're basically keeping that jaw open, but you are fatiguing the muscles. I want to forcefully kind of continue to open that mouth a little bit more so that the muscles fatigue. So I'm fatiguing, and then I leave the room for 5 or 10 minutes, come back, they're much more, and it's much easier to reduce this. Place firmly, again, use some padding, because if they bite down on this, it's going to smart. Gentle pressure. Remember, all this stuff, slow, gentle pressure. Don't start pushing, doing things real forcefully. You want a slow, gentle pressure. You got fingers under the chin, and then you're going to lift that chin up and get it slided under. I think they demonstrate a technique here.
So I'm going to be doing things really
what the patients look like. This is a bilateral dislocation.
Sit forward a little bit. So that means you can just rest your head back onto there. Okay.
Very uncomfortable.
Putting the thumbs on the rear molars, and it's a gentle pressure, and then I'll lift up with the fingers.
Sometimes when you're doing it, one side will pop in first, then the other side.
That's the sort of pressure. Mm-hmm.
He's pushing down. One went in.
Satisfying. Okay, hold on. Good. Mm-hmm. So you can see there's no push. Mm. It's really just a hold.
Gentle hold, downward pressure.
Like that. Mm. And that just gets it right up to the angle where it needs to be. Okay, hold on.
Gently place the thumbs on the mandible. See how he's kind of hooking there? Got his pinkies under the jaw. There you go, right back in. Now, just like that one kid with the patellar dislocation, things don't always go real well.
This is our young man here who's got a jaw dislocation, recurrent jaw dislocations. And you
said recurrent jaw
dislocation. It began after he had a seizure
His mom
3 years
seems
ago,
pretty
is that
calm,
correct?
doesn't she?
All right, and then he's had ever since then. He's having them even without seizures.
Right.
Okay. All right. He's had some medication, so he's a little bit sleepy,
They
but
kinda
he is,
zonked him out.
he's very willing to be a movie star today.
Yeah. We've had this done before. All right, we ready?
Give him a little propofol. Give him somebody propofol. You ought to have him on a monitor, pulse oximetry. You see they got a little oxygen on him.
60.
No verbal anesthesia going on here.
You're going to be going to sleep here soon, okay? Yep. All right.
You notice in an ER, bells are always going off. Nobody knows what the bells are telling you. They're just kind of background noise.
All right.
Monitor, he's got oxygen, he's snowed. He's using the 4x4. The kid should really be sitting straight up, 90 degrees. This guy should really be he's yanking down.
Yeah.
Somebody should be holding the head right now.
There. Felt it.
No, it's not in yet.
No, still not.
We got one side.
Yeah, I think I did. Felt something going.
Somebody please hold the kid's head.
Which side?
This is about.
I think it's the right side. All right, buddy. All right, it's going in.
What do you think? Is that
Going in and
lining up?
out.
Does that look about right?
Yeah.
Yeah. All right.
I don't think they're convinced that it's in, but I think they're done.
Then you just gotta
Hold it.
face both sides. And...
All right, so
Now they
all
end
the way
up,
around
you put
that?
this thing, it looks like, I don't know, a cartoon thing around like this. Just to keep the jaw up like this.
I'm so nervous, Joe. All right.
One last video I want to show you because it really demonstrates. You won't see the whole thing. I just want to show you because it demonstrates what's happening.
No, adjust that.
That poor kid. This is what's called the syringe method.
The temporomandibular
Looks
jaw
like a-
joint, or TMJ, allows the mouth to both
like an
open and
AI.
close. However, there are rare times when the mouth becomes locked in the open position due to a TMJ dislocation.
You can do this with
This
a syringe by
dislocation can be
yourself if you
corrected
have
by
to.
either of two methods, by yourself using a syringe or by someone else who can do it for you. In order to understand what's happening, as well as how to fix, normal jaw movement anatomy needs to be first reviewed. The key anatomic structures include the articular eminence, cupping the condylar process within the mandibular fossa. The coronoid process, although not a joint, is where the jaw muscles attach to allow mouth opening and closing. The first 2 centimeters of jaw opening is due to a purely rotational movement of the jawbone within the mandibular fossa. When the mouth opens wider than 2 centimeters, the jawbone moves forward and down along the articular eminence of the skull and out of the joint socket. A TMJ dislocation occurs when the mandibular condyle gets displaced in front of the articular
gets stuck
eminence
like
and becomes
this.
trapped in this position. The jaw is unable to close in this position because the coronoid process, which normally moves deep to the zygomatic process, is now hitting the cheekbone or maxilla. In order to reduce this dislocation back into normal position, the jaw must move downwards and back. However,
Again,
this
that's why you're
downward
doing
movement
that
is not easy
downward.
to accomplish because of the masseter muscle, which acts to keep pulling the jaw upward,
This is where
resisting the
those
downward
things you can
movement that is
fatigue it
required.
using those tongue blades.
Overall, the goal is to move the jaw downwards and back. Once the jaw has been pushed downwards, the chin is lifted upwards to complete the reduction. Traditionally, this reduction is performed with assistance. The doctor first places the thumbs over the back jaw molars. A strong and firm push is then performed oriented both downwards and back. Once the jaw has been pushed downwards, the fingers closer to the chin then pulls upward at the same time, thereby completing the reduction. However, a TMJ dislocation can be corrected by yourself
I've
using a
never
syringe.
done this, but it looks pretty cool.
The syringe
I
acts
would
like a
be willing to
rotating
try it.
fulcrum to reduce the dislocation back into normal position. The syringe is first wedged tightly into the very back of the jaw. While biting down on the syringe is rotated towards the front of the face as shown. Once the condylar process is back onto the articulate eminence, the syringe can be removed and jaw allowed to close. If necessary, these same steps can be performed on the opposite side. Afterwards, the patient should not open the mouth widely. At times, a chin strap or bandage may be required to help keep a dislocation from happening again. Eat soft foods to allow the TMJ air.
So support, ice, soft diet. You can see the syringe method here. There's the conventional intraoral. See how they have their tongue or their thumbs covered. You can actually do it extraoral also in somebody. You can, again, with your fingers, you're grabbing the lower, and on the outside, you're pushing down here. If for some reason somebody's got very poor dentition, jagged teeth, you don't want to stick your thumbs in there, you can try an external or that syringe method. Okay, I'll close on this. What do you see wrong with this x-ray? What else? So what does this person have? So they have, right? They have a fracture, right? See the fracture? They have a dislocation. This person must be accident prone. Looks like they had a prior plate put in their forearm. They also got a plate put in there. Looks like their fourth metacarpal. So some prior injuries here. This was my son after a car accident. He broke the forearm. How did he break the forearm? Playing lacrosse. He broke the fifth metacarpal. I'm going to guess probably punching somebody or something like that. Now, how do you do that one? Football? A bar fight or something? Oh, you can also see some pins there in the middle, in the third phalanx, or the third phalanx there. Some pins to this. I'll tell you, being a parent is not easy. The kids put you through hell. Fortunately, he ended up having this reduced and did well, and he's the one that's the cardiac anesthesiologist, so he's still able to function with this. We won't get into the clavicle, forearm, wrist, and other fractures. We'll save that for another day. It's already 4:30. I kept you guys way over. I apologize for that. So in summary, don't do things in a herky-jerky way. Slow, steady pressure. Fatigue muscles. Earlier reduction is better than late reduction. When you're done, try and get these things back in a position of comfort or in a neutral position to prevent a subsequent re-dislocation. Sooner is better. Okay, thank you very much. I'm leaving tomorrow. Lynn and I are heading out. We had a great time meeting you guys. We'll be back in February. I'm going to try and change up some of the lectures in February, and then we're back again in April. So I'm sure our paths will cross again at some point. So good to meet you all. And do anything that Ilshat says.